Good evening, Dr. Phil here. Today we'll be discussing on opioid pharmacokinetics. Introduction. Useful definitions. Pharmacokinetics refers to the study of the bodily absorption, distribution, metabolism, and excretion of a drug. Areas of study includes the ADME process, also known as absorption, distribution, metabolism, and excretion processes. Matrix. Various pharmacokinetic measurements are described using equations such as volume of distribution, clearance and elimination half-life. Modeling. Analysis of measured data from in vivo pharmacokinetic studies. Types of modeling includes compartmental modeling, physiological modeling, and non-compartmental modeling. Absorption refers to the uptake of substances into or across tissues. Distribution refers to the reversible transfer of a substance from one location to another within the body. Factors influencing the passage of a drug across a membrane includes molecular size, lipid solubility, protein binding, ionization, regional blood flow, and vascular permeability. Redistribution refers to the movement of a substance from an area of high regional blood flow to an area of medium or low regional blood flow. First-pass metabolism refers to the degree of metabolic breakdown of an orally administered drug that occurs in the intestine or liver before it reaches the systemic circulation. Prodrug is a drug that is converted from an inactive form to an active form by first-pass metabolism. Bioavailability refers to the fraction of a drug that reaches the circulation compared with the same dose given intravenously. Extraction ratio is the fraction of total drug removed from the blood by an organ in each pass through that organ. Volume of distribution is the theoretical volume into which a drug distributes following its administration. The formula is dose divided by C0, where C0 is the concentration of the drug at time 0. Elimination refers to the removal of the drug from the plasma via distribution, metabolism, or excretion. First-order elimination is a situation where the rate of drug elimination at any time depends upon the concentration of the drug present at that time. A constant proportion of drug is eliminated in a given time. For zero-order elimination, this refers to a situation where the rate of drug elimination is independent of the concentration of drug and therefore is constant. A constant amount of drug is eliminated in a given time rather than a constant proportion. First-order elimination may become zero-order when the elimination system is saturated. Excretion refers to the removal of a drug from the body. Clearance refers to the volume of plasma from which a drug is removed per unit time in mils per minute and may involve elimination, excretion, or both. Time constant refers to the time taken for the plasma concentration of a drug to fall to 1 divided by E constant of its former value. Half-life refers to the time taken for the plasma concentration of a drug to fall by half. Context-sensitive half-life refers to the time taken for the plasma concentration of a drug to fall by half after the cessation of an infusion designed to maintain a steady plasma concentration. The following table shows the physical, chemical, and pharmacokinetic properties of some commonly used opioids, which are important information in determining the optimal route of drug delivery in order to achieve an effective receptor site concentration for an appropriate duration of action. Morphine's pKa is 7.9, protein binding is 30%, octanol water partition coefficient is 6, clearance is 15 to 20 ml per kg per minute, volume of distribution is 3 to 5 liters per kg, terminal half-life 1.7 to 3 hours, duration of action is 3 to 5 hours. For oxycodone, the pKa is 8.5, protein binding is 45%, clearance is 13 ml per kg per minute, volume of distribution 2 to 3 liters per kg, terminal half-life 3 to 4 hours, duration of action 2 to 4 hours. For codeine, the pKa is 8.2, protein binding 20%, octanol water partition coefficient is 0.6, volume of distribution 2.5 to 3.5 liters per kg, terminal half-life 2 to 4 hours. For petidine, the pKa is 8.5, protein binding 70%, octanol water partition coefficient is 39, clearance is 8 to 18 ml per kg per minute, Volume of distribution is 3 to 5 liters per kg. Terminal half-life is 3 to 5 hours. Duration of action is 2 to 4 hours. For fentanyl, the pKa is 8.4, protein binding is 90%, octanol water partition coefficient is 813. Clearance is 10 to 20 ml per kg per minute. Volume of distribution is 3 to 5 liters per kg. Terminal half-life is 2 to 4 hours. Contact-sensitive half-life for a 4-hour infusion is 260 minutes. Duration of action is 1 to 1.5 hours after a bolus. For alfentanyl, the pKa is 6.5, protein binding 91%. Octanol water partition coefficient is 128. Clearance is 4 to 9 ml per kg per minute. Volume of distribution is 0.4 to 1 liter per kg. Terminal half-life is 1 to 2 hours. Contact-sensitive half-life for a 4-hour infusion is 60 minutes. Duration of action is 0.25 to 0.4 hours. For remifentanil, the pKa is 7.3, protein binding 70%, octanol water partition coefficient is 18, clearance is 40 to 60 ml per kg per minute, volume of distribution is 0.3 to 0.4 liters per kg, terminal half-life 0.1 to 0.2 hours, contact-sensitive half-life for a 4-hour infusion is 4 minutes, duration of action 2 to 5 minutes. For sufentanil, the pKa is 8.0, protein binding is 93%, octanol water partition coefficient is 1778, clearance is 10 to 15 ml per kg per minute, volume of distribution is 2.5 to 3 liters per kg, terminal half-life 2 to 3.5 hours, contact-sensitive half-life 30 minutes for a 4-hour infusion, duration of action 0.8 to 1.3 hours. For methadone, the pKa is 8.3, protein binding 90%, octanol water partition coefficient is 26 to 57, clearance is 2 ml per kg per minute, volume of distribution is 5 liters per kg, terminal half-life is 15 to 20 hours, duration of action 4 to 8 hours. Opioid absorption and distribution. Several factors influences the absorption and distribution of the administered opioid. The enteral route and parenteral route will be discussed. For enteral routes, examples of opioids that can be administered orally includes morphine, pethidine, oxycodone, hydromorphone, methadone, codeine, tramadol, etc. Gastrointestinal transit time. Should there be a delay in gastrointestinal transit time, such as due to ileus, the biological half-life may be prolonged with orally administered opioids. Should there be an increase in gastrointestinal transit time, for example due to diarrhea or reduced area of absorption, such as post-bowel resection, there may be reduced absorption of orally administered opioids, especially for long-acting agents. The formulation of the opioid. For enteric-coated tablets and controlled release or sustained release forms of opioids, these are slower to be absorbed as the drug takes a longer time to dissolve in the stomach. Liquid preparations of opioids are absorbed more rapidly than solid tablets. The onset of pain relief for enterally administered opioids is not as rapid as opioids that are given intravenously. Parenteral routes. This refers to any route that is not enteral. Examples include intravenous, IM, subcutaneous, transdermal, intraspinal, etc. Bioavailability is 100%. Distribution of opioids administered via IV route. After IV administration of an opioid, there is an initial rapid peak in plasma concentration. Distribution. Afterwards, the plasma opioid concentration rapidly drops as the opioid rapidly enters multiple organ systems with high blood flow, such as the brain, liver, and kidney. The initial peak plasma concentration can reduce further due to first-pass effects in the lung that may remove significant amounts of drug from the circulation. Redistribution. Subsequently, a slower drop in plasma concentration of the opioid is seen as the opioid redistributes to organs such as the muscles and later to tissues with high fat content that are less well perfused. The opioid re-enters the plasma several minutes later from compartments that received the drug during redistribution previously. These changes in plasma concentrations over time are often described by non-compartmental PK models, which describes the drug's PK behavior in terms of volume of distribution, rapid distribution half-life, slow distribution half-life, and elimination half-life. For opioids with a high volume of distribution, this is observed for lipophilic opioids with low protein binding affinity such as fentanyl. Redistribution accounts for loss of analgesic effects in drugs with a high volume of distribution. Particularly after a bolus dose or short infusion, redistribution causes significant decreases in plasma concentrations of lipophilic opioids. Examples of drugs that have a high lipid solubility and have a large VD includes fentanyl, sufentanil, pethidine, diamorphine, and lipophilic amines such as lidocaine and propranolol. These drugs may reduce pulmonary uptake of co-administered opioids. Opioids with a low volume of distribution is observed for remifentanil and alfentanil due to a high clearance and/or high protein binding. Clearance is responsible for the drop in plasma concentration and consequently the loss of analgesia when the volume of distribution is small. Context-sensitive half-life refers to the time taken for the plasma concentration to reduce by 50% after an infusion designed to maintain constant plasma concentration has been stopped. A drug has many such half-times depending on the duration of infusion, which is the context to which the term applies. Significant amounts of highly lipid-soluble opioids are sequestrated in fat stores and other body tissues after prolonged infusions. This is reflected in the context-sensitive half-life of these opioids, which increases with prolonged infusions. Apart from remifentanil, the context-sensitive half-life is increased after prolonged infusions for most opioids. Pharmacokinetics of opioids administered into the epidural or intrathecal space. Opioids placed in the epidural space undergoes diffusion across the dura into the CSF, uptake into epidural fat, and systemic absorption via blood vessels. Due to absorption into the systemic circulation via venous plexus in the epidural space, systemic concentrations of morphine, fentanyl, and sufentanil are similar when an equivalent dose is administered via the intramuscular or epidural route. The lipid solubility of an opioid administered neuraxially determines the extent of its cephalate movement in the CSF, its onset of action, and the duration of action. For less lipid-soluble opioids, such as morphine, they remain in the CSF longer and migrates to more cephalate locations. Thus, morphine, which has a low lipid solubility, has a higher incidence of nausea, vomiting, pruritus, urinary retention, sedation, and delayed respiratory depression when compared to fentanyl, which is more lipid-soluble. More lipid-soluble opioids such as fentanyl and sufentanil are limited in their cephalate migration due to uptake into the spinal cord. Regarding the onset of action, highly lipid-soluble opioids such as fentanyl, sufentanil, pethidine, and diamorphine have a fast onset of action as they cross the CSF and bind to the spinal cord rapidly. Only a small amount is available to diffuse throughout the CSF. Epidural boluses may result in early respiratory depression due to systemic absorption. For poorly lipid-soluble opioids such as morphine, they have a slower onset time. They are slow to bind to the dorsal horn receptors in the spinal cord due to its poor lipid solubility. The onset of action of intrathecal fentanyl is 5 minutes, for epidural fentanyl is 10 minutes, for intrathecal morphine is 15 minutes, for epidural morphine is 30 minutes, for intrathecal sufentanil is 2 to 3 minutes, for epidural sufentanil is 4 to 6 minutes. Diamorphine, onset of action is less than 10 minutes. For intrathecal pethidine, onset of action is 5 minutes, and epidural pethidine is 10 minutes. Regarding the duration of action, highly lipid-soluble opioids such as fentanyl, sufentanil, pethidine, and diamorphine have a shorter duration of action since they are more rapidly absorbed into the blood. Post-operative analgesia is thus limited by their short duration of action. Highly lipid-soluble opioids are more likely to act via systemic absorption. For poorly lipid-soluble opioids such as morphine, they have a longer duration of action. Special extended release preparation for epidural morphine exists. It consists of morphine sulfate pentahydrate encapsulated within 20 micrometer diameter liposomes suspended in normal saline. Onset of action is 3 hours with a duration of action of 48 hours. The dose for a single lumbar epidural injection is 10 to 15 mg. The duration of action for neuraxially administered opioids: fentanyl 2 to 4 hours, morphine 12 to 18 hours up to 24 hours, sulfentanyl 1 to 3 hours. Some sources quote 2 to 6 hours. For diamorphine, 6 to 8 hours up to 20 hours. Betadine 6 to 8 hours. Buprenorphine 8 to 10 hours. Methadone 4 to 6 hours. Factors affecting the diffusible fraction of opioids that reaches its site of action. The amount of an opioid diffusing to the site of action in the brain and elsewhere is dependent on the molecular size, lipid solubility, concentration gradient, degree of binding to plasma proteins such as albumin and alpha-1 acid glycoprotein, and tissues such as CNS lipids. This determines the availability of the unbound fraction. Co-administered drugs. Some drugs affect the blood-brain barrier's active transport systems that eliminate opioids from the brain. For example, cyclosporine enhances morphine's analgesic effects, but not that of methadone, as cyclosporine selectively interferes with morphine's efflux from the brain via specific transporter proteins. The non-ionized fraction of the opioid readily crosses the blood-brain barrier. It is dependent on plasma pH. For example, increased pH seen with respiratory alkalosis increases the non-ionized fraction of morphine, fentanyl, sulfentanyl, and remifentanil, which subsequently crosses the blood-brain barrier, and the pKa of the particular opioid. An opioid with a pKa much lower than 7.4 will have a much greater non-ionized fraction in the plasma than one with a pKa close to or greater than physiologic pH. All opioids are weak bases. This table lists the pKa of commonly used opioids. The percentage of non-ionized fraction at pH of 7.4. Alfentanil 89%, remifentanil 58%, morphine 23%, sulfentanyl 20%, fentanyl 8.5%, betadine 7%. However, of note, it is the ionized protonated form that is active at the opioid receptor site. The speed and duration of activity of opioids. Blood effect site equilibration half-life. Definition: the blood effect site equilibration half-life represents the delay between the administration of an opioid and its effect. The plasma effect site equilibration constant KEO, or its half-life, describes the delay between the peak drug concentration in the plasma and the peak concentration at the effect site. This is commonly referred to as hysteresis. Measurement. PK/PD analysis utilizes the sigmoid Emax model, which describes the effect site concentration-effect relationship. The formula is illustrated here. Various parameters can be derived from PK/PD analysis, such as PK parameters, volume of distribution and clearances, and parameters related to drug potency C50 and the onset-offset times of the drug. The effect site equilibration time is measured by assessing the effects of opioids on the EEG. The target effect when constructing PK/PD models has traditionally been the slowing of the frequency components of the EEG. Slowing of the EEG is quantified by a shift in the 95th percentile of the power spectrum, 95% spectral age frequency. C50 and effect site equilibration time derived from PK/PD studies are used to compare the potency and onset-offset times of opioids. C50 values used include those for the analgesic, respiratory depressive, and sedative effects of opioids. Determinants of the blood effect site equilibration half-life includes lipid solubility, receptor kinetics, and neuronal dynamics. The more lipophilic an opioid, the faster the transfer into the brain. Clinical utility. Understanding of the blood effect site equilibration half-life of different opioids allows the clinician to properly time dosing appropriately, especially when anticipating a stressful event, such as laryngoscopy, intubation, and skin incision. For example, Morphine is a relatively hydrophilic opioid and penetrates the blood-brain barrier slowly. A large mass of any given dose of morphine eventually reaches the receptor site because of low levels of non-specific tissue binding, for example to CNS lipids. The blood effect site equilibration half-life for morphine is about 90 minutes. Thus, a bolus dose of morphine should be given at least 60 minutes before the end of surgery when using the drug for post-operative pain relief to prevent the occurrence of a large hemodynamic response to pain. The offset time of hydrophilic opioids may also be prolonged, resulting in a longer duration of action than would be expected from the plasma half-life. This table lists the blood effect site equilibration half-life of commonly used opioids and their measured endpoint. A secondary peak in plasma concentration of opioids can occur when lipid-soluble opioids diffuse into the stomach, becomes ionized because of the low pH, and then be reabsorbed in the small intestine. The time to the loss of analgesia depends on the opioid dose, neuronal and receptor kinetic processes, the transport of the opioids from the brain to the plasma, and context-sensitive half-time. Most opioids have a very steep dose-response curve. Very small fluctuations in plasma or effect site concentrations may lead to large changes in the level of analgesia if the dose is near the minimum effective analgesic concentration, MEAC. Opioid metabolism. Most opioid metabolism occurs in the liver via phase 1 reactions, which refers to oxidative and reductive reactions catalyzed by the cytochrome P450 enzyme system, and phase 2 reactions, which refers to the conjugation of a specific substrate. Hepatic blood flow is one of the major determinants of plasma clearance for opioids, metabolized primarily by the liver. Extrahepatic sites of opioid metabolism exist, and they include enterocytes of the GI tract, kidney, and the brain. Water-soluble metabolites, such as from morphine, excreted in the gut may be metabolized by gut flora to the parent opioid and then reabsorbed via enterohepatic recirculation. Effects of medication that affect the CYP450 system. CYP450 inhibitors may increase the clinical effect of certain opioids by interfering with their metabolism, for example, alfentanil. CYP450 inhibitors may decrease the clinical effect of certain opioids by interfering with their metabolism, for example, tramadol dosage requirements may increase in patients with decreased CYP2D6 activity as metabolism of tramadol into its active compound O-desmethyltramadol is dependent on the cytochrome P450 system. Examples of CYP3A inhibitors include erythromycin, clarithromycin, diltiazem, verapamil, delavirdine, indinavir, ritonavir, saquinavir, itraconazole, ketoconazole, grapefruit juice. Examples of CYP2D6 inhibitors include clomipramine, fluoxetine, paroxetine, haloperidol, quinidine, and cimetidine. CYP450 inducers may decrease the clinical effect of certain opioids by increasing their metabolism. For example, effects of alfentanil is reduced by CYP450 inducers as it is efficiently metabolized by hepatic CYP3A3 or 4 to inactive noralfentanil. CYP450 inducers may increase the clinical effect of certain opioids by increasing their metabolism, for example, by increasing the metabolism of codeine to morphine. Examples of CYP3A inducers include rivampicin, carbamazepine, phenytoin, phenobarbital, efavirenz, nevirapine, St. John's wort, or dexamethasone. Opioid metabolites may be either active or inactive, which applies to their analgesic effects and unwanted side effects. Individual opioids shall be discussed in future videos. Genetic variability in CYP system has clinical implications. For example, patients known as supermetabolizers have increased CYP2D6 activity, are at risk of opioid toxicity from codeine, which is metabolized excessively to morphine, which is a more potent opioid. This will be discussed in the pharmacogenetics section. Examples of metabolism of opioids. Morphine undergoes glucuronidation, sulfation and N-dealkylation in the liver. Codeine undergoes O-demethylation and glucuronidation in the liver. Diamorphine undergoes O-deacetylation and glucuronidation in the liver. Buprenorphine undergoes glucuronidation and N-dealkylation in the liver. Methadone undergoes N-demethylation and hydrolysis in the liver. Methadone undergoes N-dealkylation in the liver. Fentanyl undergoes N-dealkylation and hydroxylation in the liver. Remifentanil differs from other opioids in that it has an ester linkage, which allows degradation by non-specific plasma and tissue esterases. Opioid excretion. After opioid metabolism, hydrophilic metabolites are predominantly excreted renally. A small amount of these metabolites may be excreted in the bowel or unchanged in the urine. Examples of opioid excretion. For morphine, trace amount of metabolites are excreted in the feces. 90% of metabolites are present in the urine at 24 hours. For codeine, trace amount of metabolites are excreted in the feces. 86% of metabolites are found in the urine at 24 hours. For diamorphine, trace amount of metabolites are excreted in the feces. 80% of metabolites are present in the urine at 24 hours. For buprenorphine, 70% is excreted unchanged in the feces. 2 to 13% of metabolites are present in the urine at 7 days. For pethidine, 70% of metabolites are present in the urine at 24 hours. For methadone, 30% is excreted in the feces and 60% of metabolites are found in the urine at 24 hours. For fentanyl, 9% of metabolites are excreted in the feces and 70% of metabolites are present in the urine at 4 days. For remifentanil, its principal metabolite, remifentanil acid, is excreted by the kidneys. Factors affecting pharmacokinetics. Route of administration and physicochemical properties of opioids has been discussed in previous sections. Age. Systemic doses is often calculated based on body weight. Age is also an important factor to consider when deciding on the dosage of opioids. In the elderly, there are changes in the volume of distribution. Total body water is reduced, while fat percentage is increased. The volume of distribution of water-soluble drugs is reduced, reducing dose requirements. The volume of distribution of lipid-soluble drugs is increased, which may prolong clearance. The initial volume of distribution falls because of reduced cardiac output. This reduces the dose requirement and is particularly relevant for induction agents and opioids. Metabolic changes. Metabolism of opioids are often reduced. Hepatic clearance of opioids is reduced as hepatic blood flow may have declined by as much as 40 to 50% by the age of 75 years old. This leads to increased free drug concentrations in the plasma if the usual doses of opioids were not reduced, increasing the effects of opioids. There is increased CNS sensitivity to opioid effects amongst the elderly. Decreased plasma albumin concentrations increases the free drug concentrations in the plasma. Therefore, dose requirements of drugs which are bound to albumin is reduced. Increased arm brain circulation time increases the time taken for IV drugs to take effect. In neonates, the blood-brain barrier is more permeable. Barbiturates, opioids, antibiotics, and bilirubin all crosses the blood-brain barrier more readily. All neonates, however immature, feel pain. Premature neonates may even be hypersensitive to pain due to a relative increase of transmitters mediating nociception with underdevelopment of the descending inhibitory pathways. There is increased volume of distribution. Total body water represents a greater proportion of body weight in premature and full-term neonates, which increases the necessary dose for medications that are water-soluble. There is reduced protein binding, and this results in increased free drug levels and increased activity and toxicity of drugs that are predominantly protein-bound. There is reduced body fat percentage and muscle mass. This leads to greater levels of drugs that are primarily redistributed to muscle and fat. There is reduced renal and hepatic function. This increases blood levels from normal doses of opioids that are cleared by the liver or kidneys. Gender differences. Women experience greater effects from opioids than men, which is attributed to enhanced opioid sensitivity in women and pharmacokinetic differences. There is a slower onset-offset time of morphine effects in women compared to men. This may be related to a slower passage across the blood-brain barrier or differences in receptor distribution and kinetics between men and women. Hepatic disease. Hepatic disease has unpredictable effects on opioid pharmacokinetics. The liver has a large functional reserve, so its functions are usually preserved until end-stage disease. Liver problems and resultant pharmacological effects. Reduced portal blood flow in hepatic fibrosis reduces first-pass metabolism. Hypoalbuminemia increases free drug in the plasma. Ascites and sodium or water retention increases volume of distribution. The activity of biotransformation enzymes may increase or decrease. Reduced liver cell mass will increase or decrease certain drug activities. Obstructive jaundice reduces biliary excretion of drugs. Overall, there may be little clinical significance unless there is coexisting encephalopathy. Opioids safe in liver failure are opioids that do not rely on hepatic metabolism, for example, remifentanil. Opioids to be used with caution and may require reduced dosage in liver failure. For morphine, advanced liver disease may prolong the half-life and potentiates its clinical effect. Monitor the patient for sedation. The parent drug may not be readily converted to its metabolites. Increase the dosing interval by twice the usual time period. For hydromorphone, use cautiously and monitor the patient carefully for symptoms of opioid overdose. The parent drug may not be readily converted to its metabolites. Decrease the initial dose by 50% of the usual amount. For oxycodone, use cautiously and monitor the patient carefully for symptoms of opioid overdose. The parent drug may not be readily converted to its metabolites. Decrease the initial dose by half to 1/3 of the usual amount in liver failure. For fentanyl, no dosage adjustment is needed. For alfentanil, advanced liver disease may prolong the half-life and potentiate its clinical effects. Opioids to be avoided in liver failure includes codeine, methadone, petidine, etc. Renal failure. Renal failure may have significant effects for opioids with renal excreted active metabolites such as morphine, dimorphine, and petidine. This table illustrates the recommended use of certain opioids in patients with renal dysfunction. For morphine, use cautiously and adjust dose as appropriate. For GFR of more than 50 ml per minute, 100% of normal dose. For GFR of 10 to 50 ml per minute, 50 to 75% of normal dose. For GFR of less than 10 ml per minute, use 25 to 50% of normal dose. Use cautiously and monitor patient for rebound pain effect or do not use in patients on dialysis. Metabolites of morphine can accumulate, causing increased therapeutic and adverse effects. Both parent drug and metabolites can be removed with dialysis. Watch out for rebound pain effect. For hydrocodone, use cautiously in patients with renal dysfunction. Adjust dose as appropriate. For GFR of more than 50 ml per minute, use 50 to 100% of normal dose. For GFR of 10 to 50 ml per minute, use 50% of normal dose. For GFR of less than 10 ml per minute, use 25% of normal dose. Recommended use in patients on dialysis. Use hydromorphone cautiously and monitor patient carefully for symptoms of opioid overdose. The 3-glucuronide metabolite can accumulate and cause neuroexcitatory effects. The parent drug can be removed by dialysis, but metabolite accumulation is a risk. For oxycodone, use cautiously with careful monitoring in patients with renal dysfunction and adjust dose if necessary. For GFR of more than 50 ml per minute, use 100% of normal dose. For GFR of 10 to 50 ml per minute, use 50% of normal dose. For GFR of less than 10 ml per minute, do not use oxycodone. Do not use oxycodone for patients on dialysis. Metabolites and parent drug can accumulate and cause toxic and CNS depressant effects. There are no data on oxycodone and its metabolites in dialysis. Do not use codeine for patients with renal failure or on dialysis. Metabolites of codeine can accumulate, causing adverse effects. Methadone appears safe for patients with renal dysfunction. For patients with more than GFR of 50 ml per minute, use 100% of normal dose. For patients with GFR of 10 to 50 ml per minute, use 100% of normal dose. For GFR of less than 10 ml per minute, use 50 to 75% of normal dose. Methadone appears safe for patients on dialysis. Metabolites of methadone are inactive. but use caution because parent drug cannot be removed by dialysis. Fentanyl appears safe for patients with renal dysfunction. A dose reduction is needed. For GFR of more than 50 ml per minute, use 100% of normal dose. For GFR of 10 to 50 ml per minute, use 75 to 100% of normal dose. For GFR of less than 10 ml per minute, use 50% of normal dose. Use of fentanyl in patients on dialysis appears safe, no active metabolites, and appears to have no added risk of adverse effects. Monitor with long-term use. Fentanyl is poorly removed by dialysis. For alfentanil and remifentanil, these drugs are safe in renal failure and no dose adjustments are needed. It is also safe in patients on dialysis. No active metabolites exist. For petidine, do not use in patients with renal failure or in patients on dialysis. Metabolites can accumulate, causing increased risk of opioid side effects. There are limited data on petidine and its metabolites in patients undergoing dialysis. For tramadol, in patients with creatinine clearance of more than 30 ml per minute, use 100% of normal dose. For patients with creatinine clearance of less than 30 ml per minute, use 50 to 100 mg BD, maximum 200 mg per day. Do not use if creatinine clearance is less than 10 ml per minute. Metabolites can accumulate, causing increased risk of adverse effects. Tramadol is slowly removed by dialysis with a 50% clearance by hemodialysis. Obesity. Changes in volume of distribution occurs due to smaller proportion of total body water, greater proportion of adipose tissues, increased lean body mass, increased blood volume, and increased cardiac output. For hydrophilic drugs, these drugs have a similar absolute volumes of distribution, clearance, and elimination half-lives. Base the dose on ideal body mass. For lipophilic drugs, which involves most opioids, these drugs have increased volume of distribution, normal clearance, and increased elimination half-life, especially if infusions are being used. Titrate to cardiac output, which equates to the lean body weight in a fit patient. Hypothermia, hypotension, and hypovolemia causes variable absorption and altered distribution and metabolism. Opioid pharmacokinetics. Pharmacokinetics describes the relationship between genetic variations and drug response. For example, the MC1R gene codes for the melanocortin-1 receptor. This receptor is implicated in the regulation of skin and hair pigmentation and immunomodulation. Redheads refers to a phenotype of red hair and a fair freckled skin due to specific mutations in the MC1R gene. 60% of redheads have at least 2 variant alleles of the MC1R gene. They have greater opioid sensitivity. They also require more midazolam and inhalational anesthetics compared to otherwise pigmented individuals. Mechanisms whereby the MC1R gene affects pain pathways. The exact mechanism is unknown. Proposed mechanism. Inactive MC1R causes a reflex increase in the alpha melanocyte stimulating hormone and ACTH, which may act as the endogenous ligands to MC1R and may induce neurobehavioral changes. ABCB1 gene. This gene codes for the P-glycoprotein, which is a protein involved in the efflux of xenobiotics from the brain. Variation of this gene may produce less efficacious variants of P-glycoprotein that poorly transports fentanyl away from the brain and risk increased opioid toxicity. CYP2D6 gene. The CYP2D6 isozyme is highly polymorphic with large variations between individuals in the number of gene copies in their DNA. The rate of metabolism of certain opioids depends on the number of copies a subject expresses, with greater metabolic power within the CYP2D6 pathway if there are more copies of the CYP2D6 gene. Ultra-rapid metabolizing individuals have multiple copies of this gene. Polymetabolizing individuals have 2 non-functional alleles of the CYP2D6 gene. This is important for drugs that rely on the CYP2D6 to convert an inactive precursor prodrug to an active form, such as the conversion of codeine to morphine. Polymetabolizing individuals will experience suboptimal analgesia from treatment with codeine. Ultra-rapid metabolizing individuals produces large amounts of morphine from codeine and risks opioid toxicity. Conclusion: pharmacokinetic and pharmacodynamic values vary largely among patients due to differences in physiology, underlying disease, age, weight, ethnicity, genetics, etc. The clinician should adopt a PK/PD set derived from a population of subjects whose characteristics are most identical to the individuals they are treating. These are my references. Thank you.